Hi, I'm Joseph Jamie Ravis, and here we will discuss Chapter 8, Retinopathy of Prematurity, or ROP. In this discussion, we will include information from both the retina and pediatric sections of the BCSC series for completeness. ROP is a complex disease process initiated in part by a lack of retinal vascularization in premature infants. It has a typical progression pattern, but in the earlier stages of the disease may regress spontaneously at any time. ROP is not fully understood, but elevated oxygen tension after birth relative to the intrauterine environment leads to a decrease in VEGF and insulin-like growth factor 1, causing cessation of vascular development and retinal ischemia. This leads to oxidative damage of the endothelium and drives the VEGF and insulin-like growth factor 1 levels up. The normal vascular growth process is disturbed, and the retinal vessels proliferate into the vitreous cavity at the border of the vascular and avascular retina. As the disease progresses, vitreous hemorrhage and traction retinal detachments may occur. The end stage of untreated ROP is the development of a dense, white fibrovascular plaque behind the lens and a complete retinal detachment. In the United States, ROP that is severe enough to require treatment occurs in approximately 1,100 to 1,500 infants annually, and of these, 400 to 600 will never achieve vision better than 2,200. Four classification concepts have prognostic and pathophysiologic importance: zone, which is the location of the disease; stage, which is the severity; the extent is the number of clock hours involved; and plus disease is classified as whether or not it's present. The location of ROP consists of three zones. Zone 1 is defined as a circle with a radius of 30 degrees centered on the optic nerve. The distance from the optic nerve to the fovea is 15 degrees, and twice this distance will give us Zone 1, which is shown here in red. Zone 2 extends from Zone 1 to the nasal oris aorta, and Zone 3 extends to the temporal retina. Embryologically, retinal vascularization begins at the optic nerve at approximately week 16 of gestation, then proceeds outward radially from the optic nerve head to the periphery, and is completed nasally by approximately 36 weeks gestation and temporally by 40 weeks gestation. Stage 1 is defined as the presence of a demarcation line with no height or elevation between the vascularized and non-vascularized retina. Stage 2 is the presence of a demarcation line with height, width, and volume creating a ridge. Small isolated tufts of neovascular tissue lying on the surface of the retina may be present, and these are called popcorn lesions. Here we see an elevated ridge at the border of the reddish vascularized tissue and the gray avascular retina. Of note, while the retina is derived from neuroepithelium, the tissue ridge shown here is actually mesenchymal in origin. Stage 3 consists of a ridge with extraretinal fibrovascular proliferation. Stage 4 is a partial retinal detachment. In Stage 4A, the retinal detachment is extrafoveal or not involving the fovea, whereas in Stage 4B, the fovea is involved. The red area here shows a temporal retinal detachment involving the fovea. Stage 5 is a total retinal detachment. Here we can see the preretinal contraction, and as it progresses, it acts as a purse string, causing the retinal detachment to narrow. Also, plus disease can be seen in each of these photos. Plus disease is venous dilation and arteriolar tortuosity of the posterior retinal vessels in at least two quadrants due to shunting of blood, signifying severe disease. Iris vascular dilation and vitreous haze may also be present. Both photos show pronounced plus disease, and also inferior temporally here we can see preretinal proliferations and peripheral avascular retina. Here are two more fundus photos showing pronounced plus disease. On the left, there are preretinal proliferations of vessels causing preretinal hemorrhages, and on the right there is plus disease without notable preretinal fibrosis. Plus disease is seen here on the right side. However, not all vascular dilation rises to the level of plus disease. The term pre-plus refers to vascular dilation and tortuosity that are abnormal, but that are less than that seen here on the right photograph. Table 8-1 here summarizes the zones, stages, and plus disease we just discussed. Aggressive posterior ROP, formerly known as rush disease, is a severe form of ROP defined as Zone 1 or posterior zone 2 disease associated with plus disease involving all 4 quadrants of the posterior pole. Here we can see flat neovascularization at the junction of the vascularized and avascular peripheral retina. This disease is difficult to treat and often has a poor prognosis without treatment. Aggressive posterior pole ROP typically can progress quickly to stage 4 or 5 ROP. Here we can see a patient on the left prior to treatment and on the right just after laser treatment was applied to the peripheral avascular retina. The cryotherapy for retinopathy of prematurity trial, or ROP, studied the efficacy of cryotherapy versus observation and defined threshold disease. The definition of threshold disease can be memorized by using the 1, 2, 3, 5, 8 rule. That is, ROP in zones 1 or 2 with stage 3 disease and 5 continuous or 8 total clock hours of extraretinal neovascularization with plus disease meets the criteria for threshold disease. This figure shows in the right eye an example of what 8 total clock hours of disease looks like, and the left eye shows an example of what 5 continuous clock hours looks like. The ROP disease shown here is all within zone 2, and the plus disease is shown here. The early treatment for retinopathy of prematurity trial, or ET-ROP, compared laser to observation in the treatment of ROP. They also defined the term pre-threshold disease as all zone 1 and zone 2 ROP changes that do not meet the criteria for treatment defined by threshold disease, except for zone 2, stage 1 or 2 disease without plus disease. ET-ROP further divided pre-threshold ROP into types 1 and 2 disease to delineate which babies would benefit from treatment before the development of threshold disease. Type 1 ROP benefits from treatment as it is more advanced, while Type 2 ROP warrants close observation. The way I remember which trial defined Type 1 and 2 disease is by thinking about the alien from the movie E.T. He was a peaceful alien, and the sign for peace is 2 fingers. Thus, Type 1 and Type 2 ROP were defined by the ET-ROP study. Of note, an eye is classified according to the most advanced disease noted. However, documentation should reflect all zones, stages, and extent of disease observed. Overall, eyes with ROP in zone 3 typically have a good prognosis, whereas those with more posterior disease have a more non-perfused retina and thus a more worrisome prognosis. Table 8-2 here summarizes aggressive posterior ROP, threshold, and pre-threshold disease. Although the current understanding and pathophysiology of ROP is incomplete, it is thought of as a 2-phase process. In the first phase, which occurs approximately before 31 weeks gestational age, it is believed that an increase in the infant's systemic oxygen tension that occurs following birth and the commencement of breathing by the infant leads to a decrease in the level of hormones and growth factors that govern normal vascular development in the eye, such as vascular endothelial growth factor and insulin-like growth factor 1. This decrease leads to a cessation of vascular development and the retina becoming ischemic. The second phase of ROP begins at approximately 31 to 34 weeks gestational age. It is characterized by an abundance of growth factors secreted by the ischemic retina, particularly VEGF and insulin-like growth factor 1, among others, as well as oxidative damage to the endothelial cells. This leads to disorganized vascular growth and the 5 stages of ROP that we have already discussed. Although the systemic and/or local tissue factors that influence progression and regression of ROP are not fully known, the time course is predictable. ROP is a transient disease in the majority of infants, with spontaneous regression occurring in 85% of eyes. The initial clinical signs of regression is the development of a clear zone of retina beyond the shunt, followed by the development of straight vessels crossing the shunt and an arteriovenous feeder extending into the avascular retina. Threshold ROP, which benefits from treatment, eventually develops in approximately 7 to 10% of infants with a birth weight of 2,500 grams or less. Eyes that demonstrate progression undergo a gradual transition from the active to the cicatricial stage of ROP, which is associated with various degrees of fibrosis, contracture of the proliferative tissue, vitreous and retinal traction, macular distortion, vitreous and retinal hemorrhages, and retinal detachment. There are many associated conditions and late sequelae with regressed ROP. These include myopia with astigmatism, anisometropia, strabismus, amblyopia, cataract, glaucoma, macular pigment epitheliopathy, vitreoretinal scarring and adhesions, traction retinal detachment, although rhegmatogenous retinal detachments may occur later in life. Although rare, both angle closure and pupillary block glaucoma may occur in myopic eyes with cicatricial ROP. Angle closure glaucoma typically occurs before 10 years of age, but it can occur well into adulthood in affected individuals. ROP and its sequelae can cause problems throughout a patient's life, and therefore long-term monitoring is crucial. Also, patients may have anomalous foveal anatomy and macular dragging, which we will focus on further here. Here we see anomalous foveal anatomy. Normally, the fovea is located here at the location of the X. However, with the cicatricial changes that occur in ROP, the fovea may be dragged temporally, as is seen here. This has consequences, since when there is macular dragging, the fovea moves temporally, causing a large angle kappa between the visual axis, seen here in green, and the pupillary axis in red. This gives us the angle kappa. This presents as a pseudoexotropia. The figure here on the right shows a pseudoexotropia in a patient that is actually fixating with their left eye. Alignment of the eyes are straight, however they appear turned due to macular dragging. The patient has a large angle kappa as a result of macular dragging, and this highlights the importance of a thorough retinal examination in all patients with strabismus. Here is a more in-depth look at the different axes of the eye and how they relate to macular dragging. The red line here is the pupillary axis, which is a line perpendicular to the surface of the cornea, passing through the center of the pupil. The visual axis extends from the point of fixation, which is the fovea, through the nodal point of the eye. The angle between the pupillary axis and visual axis is known as kappa, and the way I memorize this is that kappa is a very important angle, or VIP, standing for visual and pupillary axis. The optical axis of the eye extends from the anterior to posterior pole of the eye and is defined by the geometric centers of the crystalline lens and cornea. Here we see the angle alpha, which is made up of the pupillary and optical axis. Here we can see the macula being dragged temporally, thus increasing the angle of kappa, leading to a pseudoexotropia in the patient. Of note, the nodal point here of the eye is close to the posterior aspect of the lens, and this explains why a posterior subcapsular cataract is more visually significant than an anterior opacity. All infants with a birth weight of less than 1,500 grams or a gestational age of 30 weeks or less should be screened. In addition, if the attending pediatrician or neonatologist deems the child to have had a high-risk or unstable clinical course, children between 1,500 and 2,000 grams or those greater than 30 weeks should be considered for screening. One caveat of paramount importance is to recognize that screening criteria and risk factors developed in one country do not necessarily apply in another country, especially if the level or quality of available medical and perinatal care is not comparable. For example, in some countries, ROP is seen in babies with a higher birth weight than in the United States. Thus, screening criteria need to be developed that reflect local experiences. Systemic IGF-1 levels and weight gain are also associated with ROP risk. A newer model, the Weight IGF-1 Neonatal ROP algorithm, or WINROP algorithm, is being assessed for more targeted screening efforts. In some studies, this model has been 100% sensitive in detecting at-risk infants, while identifying as many as 90% of infants that do not need screening. The WINROP model has led to interest in developing other, preferably simpler algorithms to identify infants at risk for ROP who require screening. The first ROP screening examination should generally be performed between 4 and 6 weeks of postnatal age, or alternatively between 31 and 33 weeks post-conceptional or postmenstrual age, whichever is later. For example, babies born between 24 and 27 weeks will have their first ROP screening at postmenstrual age 31 weeks. After each evaluation, the follow-up interval should be determined based on the disease features. More severe disease indicates a need for shorter follow-up intervals. For example, 1 week or less follow-up is recommended for most Zone 1 disease unless regressing, whereas longer follow-up is recommended for Zone 3 disease. These are the criteria for when to discontinue ROP screening examinations: when there is fully vascularized retina, when there is zone 3 vascularization without previous zone 1 or 2 ROP, when there is lack of development of pre-threshold or worse ROP by 50 weeks post-menstrual age, or there's regression of ROP in zone 3 without abnormal vascular tissue capable of reactivation in zones 2 or 3. Ultra-wide-angle 120-degree fundus photography of premature infant eyes is very useful for documenting the findings, for assessing any progression, and for use in screening of ROP. Remote screening of fundus images has established itself as an efficient and cost-effective method for screening premature infants. A study by the Photographic Screening for ROP Cooperative Group, or PhotoROP, concluded that remote interpretation of weekly digital fundus images was a useful adjunct to conventional bedside ROP screening by indirect ophthalmoscopy. As ROP became a clinically distinct and recognized entity in the 1950s, supplemental oxygen administration was implicated as a major causative factor. After substantial reductions in oxygen use, the incidence of ROP decreased dramatically. However, many of the infants incurred adverse neurologic outcomes as an unintended consequence of the oxygen reduction, and infant deaths rose. Once oxygen was again used more liberally, neurologic outcomes and survival improved with the consequence of worse ROP. Preventing ROP begins with preventing prematurity through optimal prenatal, perinatal, and postnatal care. Avoiding extremely low birth weight and short gestational ages may be the most important factors in prevention. Also, there is mounting evidence that the postnatal clinical course alters the risk as well. That is, very sick premature infants are at greater risk of developing ROP. Specific factors that have been shown to increase the risk of ROP include sepsis, blood transfusions, a slow rate of postnatal weight gain, and diet. In 1988, the cryotherapy for ROP study demonstrated that ablation of the avascular anterior retina in ROP eyes with threshold disease reduced the incidence of unfavorable outcomes such as macular dragging and retinal detachments by half. Treatment reduced these sequelae from 47% to 25% at 1-year follow-up, and the visual results were shown to parallel the anatomical results as well. At 10 years follow-up, eyes that received cryotherapy were still much less likely to be blind than untreated control eyes. The early treatment of ROP, or ET-ROP study, examined infants with bilateral high-risk pre-threshold ROP. They were randomly assigned to receive early ablation with high-risk pre-threshold disease or to conventional management according to the cryo-ROP study. Below we can see the exact criteria for type 1 and type 2 ROP. High risk was determined using a computational model based on the natural history cohort of the cryo-ROP study. This model used demographic characteristics of infants and clinical features of ROP to classify eyes with pre-threshold ROP as either high risk or low risk. In infants with high risk pre-threshold ROP, earlier treatment was associated with a reduction in unfavorable visual acuity outcomes from 19.5% to 14.5% at 9 months. Also, there was a reduction in unfavorable structural outcomes from 15.6 to 9.1% at 9 months. This study determined that the clinical categorization of pre-threshold eyes into type 1 or type 2 ROP achieved very similar results to the computational model for risk assessment in pre-threshold eyes. They concluded that type 1 ROP should be treated with peripheral retinal ablative treatment, while type 2 ROP should be monitored in short intervals. Currently, peripheral retinal ablative treatment of threshold and pre-threshold type 1 ROP should be performed. Treatment should be administered within 72 hours of determining its need, and laser is preferred over cryoablation whenever possible, as laser is associated with less treatment-related morbidity. Laser should be applied using an indirect ophthalmoscope in a confluent or semi-confluent scatter pattern. Here we can see laser photocoagulation applied to the anterior avascular retina. Laser treatment should not be applied directly to the ridge. There are side effects to laser treatment, however. In the horizontal meridians at 3 and 9 o'clock, laser treatment should be applied in a lighter pattern to avoid damage to the long ciliary vessels and nerves. Damage to the long ciliary nerves can lead to mydriasis, decreased corneal sensation, and loss of accommodation. Damage to the long ciliary vessels can lead to anterior segment ischemia. The most serious side effects include respiratory and cardiorespiratory arrest, which can occur in up to 5% of treated infants. Treatment should be performed in conjunction with a pediatric consultation and with systemic monitoring. The use of systemic analgesia is also advisable to minimize stress and risk to the infant, and some neonatologists prefer that infants undergo treatment with general anesthesia. This wide-angle photograph shows threshold ROP with plus disease and a ridge. We can also see arborization of the vasculature leading up to the ridge and associated fibrovascular proliferation closer to the ridge. A notable finding in active ROP disease is the increased and abnormal terminal arborization of retinal vessels as they approach the ridge or shunt. As this eye has threshold disease, it was treated with laser. On the right, we see a different patient with pigment clumping denoting healed laser photocoagulation. Also, there is normalization of the posterior retinal vasculature. The BEAT ROP study was a prospective, randomized trial assessing laser versus intravitreal bevacizumab monotherapy. Those included had Zone 1 or posterior Zone 2 Stage 3 ROP with plus disease. Compared with conventional laser therapy, a statistically significant treatment benefit for bevacizumab was demonstrated for Zone 1 ROP. However, Zone 2 disease had similar outcomes whether treated with laser or bevacizumab. Some potential benefits with bevacizumab treatment include normal peripheral retinal vascularization may continue after treatment with bevacizumab, whereas when treated with laser therapy, there is permanent destruction of the peripheral retina. A significant drawback of bevacizumab treatment is recurrence of ROP. Recurrences occurred significantly later with bevacizumab than with laser therapy. Therefore, prolonged and close follow-up is essential. Infants with bevacizumab have an incidence of recurrence of 8.3% and a mean recurrence time of 51 weeks. In contrast, ROP reactivation is rarely seen following ablative therapy with laser. If available, fluorescein angiography is a great tool for follow-up of treated patients to assess eyes for reactivation or progression of the retinopathy. There is an uncertain safety profile. Continued investigation for long-term safety and efficacy data remain critical for understanding the exact role of anti-VEGF therapy in the management of this unique population. When treating ROP with anti-VEGF therapy, the intravitreal injection preparation is very similar to that of the adult, with the eye being sterilized with 5% betadine solution. However, given the infant's small eye size, the injection site should be 1.5 mm posterior to the limbus compared with the 3 to 4 mm in the adult. Meticulous attention must be paid to the lens anatomy to avoid puncturing it with the injection needle. The lens is larger in premature infants relative to the overall eye size compared with an adult. Risks associated with intravitreal injections include cataracts, endophthalmitis, bleeding, and retinal detachment. Below you can watch a video of Dr. Barakal performing a bedside intravitreal injection in the NICU on a premature baby. Eyes with stage 4 ROP require surgical intervention using scleral buckling or vitrectomy to alleviate the vitreoretinal traction causing the retinal detachment. Eyes undergoing surgical intervention at stage 4A rather than later stages 4B or 5 have more favorable outcomes. Unfortunately, the visual prognosis is poor. For eyes with stage 5 disease, vitrectomy combined with dissection of the fibrovascular membranes and adherent vitreous has been successful in fully or partially reattaching the retina in approximately 30% of eyes. And among those with initially reattached retinas, only 10% eventually have ambulatory vision. Also, if a drainage retinotomy is performed or an iatrogenic break occurs during the vitrectomy, the prognosis for that eye becomes universally poor. Here are a couple pictures from a vitrectomy for stage 5 ROP. The full video can be seen in the link below, but there are a couple of interesting points to highlight here. You can see the infusion port hooked up to the trocar in the anterior chamber. Additionally, the light pipe and vitrector were placed into the anterior chamber through a small paracentesis in the cornea. This approach through the anterior chamber is quite unique. Also, the eye was filled with viscoelastic at the end of the case rather than gas or oil.